Right, we've been talking about the ear and we went into the cochlea and all the complicated stuff in there. So this week I thought we'd go back outside and talk about this thing. The auricle, or the pinna. And there are a whole bunch of parts to it, but it's not terribly complicated, which is why I thought I'd do it. But since we're looking at this part of the body, I thought we'd take this opportunity to also talk about skin cancer, as this is a lump of skin what is sticking out of the side of your head and somewhat susceptible to it. So what have we got? Well, you see a little bit of blue back here. We've got the bone of the skull. This here is the ear canal, or in anatomy we like to call it the external auditory meatus or the external acoustic meatus, and this is the temporal bone right at the side here. So that bony canal is passing into the petrous part of the temporal bone, where we found the tympanic cavity, which is the middle ear, and then we find the structures of the inner ear, that is the cochlea and the semicircular canals. So out here then, this is the external ear, and we have this bony canal, but it's extended by cartilage, and this is elastic cartilage, which you well know because of course your ear is pretty elastic, right? And it's got a lot of shape to it. Well, why? So it's an opening for the external auditory meatus. The reason for that canal is to transmit pressure waves, air waves, to the tympanic membrane, which is then going to transmit sound, transmit those vibrations to the cochlea. We did that in the cochlea video, go and have a look at that. We also did the ossicles in the middle ear video, go and watch that. So what the external ear does, what all this funky apparatus does out here is, supposedly it funnels the sound into that canal. So instead of just having a small opening, it has a large opening to capture those vibrations and force them's the wrong word, but you know, help direct them into that ear canal. I've read in some places that you know, increases the force of vibrations and stuff. I don't know how much of that is true. Funnily enough, I've never really looked into the physics of the external ear. Maybe I should. I think it's of somewhat significant interest to zoologists. Us anatomists maybe less so. But the reason for the shapes here then is to funnel that sound, but also in humans it seems to exaggerate or amplify sounds in the frequencies associated with human speech, which is a cool idea, I thought. So some of these shapes have evolved for that reason. And also the other thing about ears is directional information, right? So in you, the reason we like stereo sound so much is we know, we can hear where sound is coming from, right? We can hear the direction of a sound. If a sound occurs, we know where it is. And because of some cool wiring between bits of the brain, if a sudden loud sound occurs, we turn towards it before we even realise we've turned towards it. So we're able to work out where a sound is coming from. And these shapes of the external ear, apparently there's some funky physics going on there which helps with that directionality. Now we have a bunch of muscles associated with the ear, which I think I touched on briefly when we were talking about the muscles of facial expression. But animals, we can move our ears if you practice hard enough, but animals can move their ears. Horses are a good example of this. So they can help themselves work out where a sound is coming from, and their ears will move around to reflect that. And of course the movement of their ears and the ears of other animals also is a bit of body language, right? It's a sign of their mood. It's a behavioural thing. Think about dogs, you know, the ears prick up and that sort of thing. But for humans, otherwise it's kind of a lump of elastic cartilage stuck on the side of your head, covered in hairy skin that helps take sound and funnel it into the internal acoustic meatus. Now we've, this being anatomy, where we like to name everything, if anybody ever says that, did you know there's no word for the such and such a part of the body. People say that about the back of the knee. It's not true. Anatomists love naming things. So all of these features on the ear have got a name. We tend to call the external ear the auricle, with an AU, rickle, not an O-rickle, which literally means ear. I think that's the Greek, right? Oris, as in oris means ear, I think. The Latin word for fin or limb, no, fin or wing, is something like pinna, pins, pin. So it also gets called the pinna, often more so in animals, I think, but the pinna or the auricle, that's the external ear. Now, this big curve around here, and you can feel all these curves on yourself, right? You're probably very familiar with all these curves and shapes. This is the helix, you know the word helix, so that's the helix. This here then, that's the anti-helix. The groove under here gets called the scapha. Now, do you see how the anti-helix kind of continues? There's these two like stretched out bits. These are crura. So we have the superior crus and the inferior crus. We see crura elsewhere in the body, also kind of supportive, stretched things, right? Similar sorts of shape. And then there's that depression there. That nice depression, which is always good to... So that depression there is the triangular fossa or triangular depression. It's got some funky Latin names as well, but I forget. So that's the kind of the upper part of the ear. And then down here, this very familiar bit here, this is the tragus. This is the antitragus. And this notch here gets called the intertragic notch. Really, it's spelled tragic. Intertragic notch, the intertragic notch, and you might see a few variations on that word as well for this bit in here. And then we're getting into the hole here. So this space in here gets called the concha. Concha meaning shell, right? And the concha's got two parts. So the upper part in here, so if this is all the concha, the upper part of the concha here gets called the cimba, and then this is the opening to the external auditory meatus here in the lower part. Interesting thing about tragus, it comes from the word meaning goat, and the reason this gets called tragus is because these parts of the ear grow long hairs, I guess, like the hairs of a goat. And then of course this last bit down here is lobule. So there are a lot of names for the parts of the ear. Now, why would you need to know all of those names? I don't know. Maybe the ear, nose and throat guys will tell you why that's so important. One reason is, as I alluded to earlier, is that because the ears stick out from the body, they get exposed to UV irradiation. So they're a site of high risk of skin cancers. And we'll come back to skin cancers in a moment, but if we're thinking about skin cancers, and most skin cancers aren't terribly dangerous, but we do always need to think about the spread of cancer. So if we're thinking about the ear, let's have a think about the blood supply, the innervation and the lymphatic drainage. So the blood supply, there's kind of like a region posterior to the external auditory meatus and a bit anterior, and that's a divide. We've talked about pharyngeal arches briefly before, but the embryology of the pharyngeal arches kind of describes this a little bit. But so posterior, right? So the blood supply to the posterior part of the ear is from the posterior auricular artery. Auricle, right? So posterior ear, posterior auricular artery is very sensible once you kind of get the hang of the lingo. Whereas the anterior part of the ear then, so anterior to the external acoustic meatus, that is supplied with blood by the superficial temporal artery, which of course is running up to the temporal region up here, and you can feel the pulse of it. Both of those arteries are branches of the external carotid artery, which again makes sense because of course the external carotid artery is supplying blood to the structures of the face and this region in general. Now that crossover is also seen in the innervation. So the posterior part of the ear, so kind of the external ear, posterior to the external acoustic meatus. That's innervated actually by nerves from the neck. So branches from spinal level C2 and C3 and the cervical plexus. Those are sending branches to the posterior ear, whereas the anterior ear is a bit more part of the face. It's kind of like it's associated with the first pharyngeal arch, so that is innervated. So the sensory innervation from the skin is carried by the trigeminal nerve, and the third branch of the trigeminal nerve, the mandibular branch of the trigeminal nerve. All right, and interestingly, as you kind of get in here, as you get into the concha and into the external auditory meatus, some of that sensory innervation is carried by the vagus nerve and carried by the facial nerve. We've talked before about how these nerves are kind of passing through this region. And one interesting thing that leads to in some people is that when you're poking that region, sometimes you get sensations in the back of your throat. Sometimes sensations in the back of your throat also feel like they're in your ear, and your ear needs a bit of a tug. So there's like kind of an overlap, kind of vagus nervy between the oropharynx, the soft palate, and the external acoustic meatus here, right? So that's a bit weird in some people. Sometimes doing that in some people will cause an involuntary cough reflex because of the vagus nerve's association with both bits. Interesting factoid. Know anybody that coughs when you do that? So in terms of the actual nerves that are getting to these regions, then it's the great auricular nerve for the posterior part of the ear, which has come from the neck. If you look at your dermatome man, you'll see that. And it's the auriculotemporal nerve innervating the anterior part, which is a branch of the trigeminal branch of the, which is a branch of the mandibular branch of the trigeminal nerve. Yeah, auriculotemporal, greater auricular. Yeah. Lymphatic drainage then, similarly, the ear is kind of divided a little bit. So we've got superficial cervical lymph nodes and deep cervical lymph nodes in the neck, working their way back down to get back to the circulatory system. So with the lateral part, in the superior part of the lateral part of the ear, the skin here, it'll drain its lymph actually to superficial parotid lymph nodes, whereas the cranial side, like the skin on the other side of the ear, right, on this side up here, or most of around this sort of region, is more likely to drain its lymph to mastoid lymph nodes, so lymph nodes around the mastoid process here, which is this bony bit you can see around, you can feel around here, which will then drain to, that'll then drain to deep cervical lymph nodes. The rest of the ear will drain its lymph to superficial cervical lymph nodes, which will then carry on to deep cervical lymph nodes. So if somebody does have, a tumour developing on the ear and you want to palpate lymph nodes that the skin of the ear drains to, it's around the parotid gland, around the mastoid process, and then you're looking in the neck, those superficial and deep cervical lymph nodes. All right. Now, what about ear cancer then? Ear cancer. What about skin cancer of the ear? So I thought we'd take this opportunity to talk about skin cancer, because I don't really know where else it'll crop up. But one of the important things about the features of the external ear is that, as I said, they stick out from the body. So there are three types of skin cancer: SCC, BCC, and melanoma. So those are squamous cell carcinoma, basal cell carcinoma, and melanoma, which also gets called malignant melanoma. And we see squamous cell carcinomas and basal cell carcinomas are much more likely to occur in regions of the body exposed to the sun. And if you've been watching my vlogs, you'll see that I'm outdoors a lot, all year round. If I'm rock climbing or running or walking or whatever, I feel naked if I go outside without sunscreen on, without sunscreen. And I pay particular attention to my ears and my nose and cheeks and everything, but particularly these guys, because these things stick out. And these are very common sites, the nose and the ears, for developing SCCs and BCCs, because UV irradiation, especially UVB, can damage the DNA in the cells of the skin. And of course, the skin, as you're well aware, hairy skin. The surface of the skin is constantly being lost. That's the dust in your house is mostly your skin cells. And that's how we make a nice protective waterproof covering for ourselves, is we make this layer of skin and we shed the outer layer and keep replacing it so it never wears out. And we have, you can see here, look, we've got the various layers of the skin, but we've got the dermis down here and we've got the epidermis up here. So the epidermis, which is quite thin in the skin around here, the epidermis, you have a layer of progenitor cells, like stem cells, which will constantly produce new skin cells, which get pushed to the surface and then lost, and new ones follow on behind. So we always have this covering, and if we get a cut or something, then cells can migrate across and cover the whole. It's very clever. It's a fantastic organ. But because these cells are always dividing, they're always proliferating, it means that if a mutation in the genes that are error correcting that proliferation are damaged and you lose that error correction, then there's a much higher chance of one of these cells just starting to divide and never stopping. And that's essentially what a cancer or a tumour is, right? It's a cell that keeps dividing and dividing and dividing and proliferating, gets bigger and bigger and bigger and bigger and bigger. Now, the squamous cell carcinoma is a cell a little bit higher up in the epithelium that has undergone that change, and in the upper layers of the skin, the cells get filled with keratin, which makes them waterproof, right? So a squamous cell carcinoma looks a bit different to a basal cell carcinoma. So a squamous cell carcinoma then, they tend to be fairly slow growing. They might grow over weeks or months. And it might appear as a red lump. And normally, we get red. I got some bites from insects and what have you on my skin, on my elbows and what have you. And of course, most of these red bumps and what have you that disappear fairly quickly. So if you find a red bump that has appeared and doesn't disappear after 4 weeks, that's an alarm sign. They're more easily ulcerated, they bleed more easily than other lesions, because the squamous, what squamous means is the flat cell, right? So the squamous cell carcinoma, because it's in the upper layers of the skin, it might become scaly and hard because of that keratin, and 90% of them are caused by damage to DNA, by UV irradiation, but also by aging and smoking. So you have all those other risk factors on top. And they don't tend to spread, and it's when a carcinoma spreads that it's dangerous. They don't tend to spread, but they can spread. They can go deeper into the skin and pass into lymph nodes and then start to spread. So they are somewhat dangerous, but they tend to stay on the outer part of the skin and they're slow growing. You need to remove it early because it will continue to grow, and of course as it grows it's going to start to incorporate more tissues, but also to remove it you're going to have to cut it out, and if it grows and grows and grows it gets harder to cut it out. If you cut out a big section of skin, then you're going to need a skin transplant, right, to cover over the space you've cut out, so it gets a lot more complicated. So just like any other cancer, if you spot it early you can treat it early, and you can get a biopsy and get the path lab to tell you what's really going on in there. So that's a squamous cell carcinoma, and that's in the upper layer of the epithelium. A basal cell carcinoma, if it appears on the skin of the ear or the nose, is somewhat similar, but it's in the deeper layers of the epithelium down here. So it's in the. This is why it's called a basal cell carcinoma. It's in the basal layers, the lower layers. Again, isn't terribly dangerous. It's slow growing. Again, you might get a red or a pink lump. It might appear waxy rather than scaly because it's a different type of cell. And when these things grow, they muck up the normal processes that occur when you're making new skin, right? It all goes a little bit awry because they're not making skin, they just keep proliferating. So you might get a red lump, waxy, more likely to ulcerate, more likely to bleed again. The basal cell carcinoma is the most common type of skin cancer, and it's likely to keep growing and keep growing and keep growing if you leave it. This one, because it's a bit deeper, it's a bit more likely to invade the deeper tissues. So again, it's really sensible to spot it soon and get it biopsied and get it removed if it is a basal cell carcinoma. And again, it's one of those things that, you know, most things on our body, on our skin, heals up within a matter of a couple of weeks. So if this thing has been there for 4 weeks or more, alarm bell should be ringing and you should be getting it checked out. It's more likely to involve deeper tissues and maybe become harder to remove than a squamous cell carcinoma. Now, if you have an SCC or a BCC removed, there's something like a 50% chance of getting another one in the same spot within 5 years, I think, for an SCC, within 3 years for a BCC. So once you've had the development of one of these things, you're more likely than normal to develop another one. So the SCC and the BCC, watch out for those. They develop on skin that is exposed to the sun, to UV radiation. Now the other type, the melanoma, is a much more dangerous form of skin cancer. Now a melanoma forms from the cells that pigment our skin, right? So melanocytes are responsible for changing the colour of our skin. Right now it's the summer. We've actually had a lot of sun in Wales, but don't tell anybody. It's been wonderful, which means that with all the running and climbing I've been doing, my skin has started to change colour, so it's a lot fairer here and a little bit darker on that side. Like I say, I love to use lots of sun cream because I'm an anatomist and I've seen lots of tumours on skin. The melanocytes, they can also form tumours. And the risk here is that the melanocytes, when a melanocyte goes rogue and starts to proliferate and form a tumour, it's much easier for that cell to penetrate deeper under the skin and invade blood vessels and invade lymphatics. And when it does that, then it spreads around the body and then it becomes very, very dangerous. A melanoma can form on normal skin, as in skin that isn't a mole, but you see these moles here. I've got some we've all got little moles on us, right? These little moles, there's a 50% chance if a melanoma occurs that it will occur on an existing mole or a spot like this, and a 50% chance that it will occur on normal skin, as in skin that's not a mole, right? So it doesn't always form from moles. But you should watch out for, so it's going to be, if it forms, it's going to be like the colour of a mole. It's going to be very dark, and you want to watch out for moles that are kind of irregularly raised, that are changing fairly rapidly, that again become sore or itchy and red and reddened and bleeding and that sort of thing. Moles that suddenly appear and that sort of thing. So in that sense, I don't know how many people have got moles on their external ears, but while SCCs and BCCs are far more common to be found if they occur on the external ear, a melanoma could form there as well. Now, if you spot the melanoma early and it's removed, actually I've got a big scar on my back. I had one removed years ago, and I'd much rather have a scar on my back than, you know. If it doesn't spread, there's a really, really high 5-year survival rate. If the melanoma has started to spread, then it's incredibly dangerous and that survival rate drops right off. So be vigilant. One thing my GPs tell me to do is take a photo of your back, or get somebody else to take a photo of your back, because that's the bit I can't see, everything else I can, and then compare it to your back. every month or couple of months or what have you, and see if anything's changed. Of course, the flip side is that melanin it protects the skin against UV radiation. So as someone with very fair skin, the risk of forming squamous cell carcinomas and basal cell carcinomas is much higher in me than someone that had much darker skin. So melanin's a good thing, just sometimes the body mucks up and it all goes a bit awry. Ah well. Right. So that's it. Those are the structures of the external ear, the external auditory meatus, and bits and bobs. So you can see why I thought I'd talk a little bit about the skin and skin cancer, partly because it's nice and sunny outside, but also, you know, that information might be helpful. Keep an eye on your skin. Watch out for these changes. Stay safe out there. That sun, you know. We don't normally have to worry much about the sun in Wales. Usually it's fairly grey and wet. Right, okay, hope that was useful. I reckon next time we should go back into the inner ear and have a look at the vestibular system, the semicircular canals and balance and that. All right? Right.